Hello and welcome or welcome back to the COVID Advocacy Exchange. I'm Dave Fuhr with Grit, and I am honored to be able to spend this time with you. As we get ready to launch into this panel today about telemedicine and access to care, the most important thing I can do is keep my remarks short. This panel that you're about to be a part of are some of the most expert individuals and humans tackling a really complex topic that is affecting many of us with a diagnosis. This Monday was my first time ever using telemedicine to visit with my doctor. I'm a two-time cancer survivor, and as you all know, going through diagnoses, these visits come with a lot of emotions, a lot of questions, and it put me in a place this week to really feel, not just know, but feel how important this topic is. We heard last week on our panel about reopening clinical trials safely that Memorial Sloan Kettering, for example, has shifted from 5% of their patient visits being telemedicine to now more than 80% being telemedicine based. And anytime we face this kind of shift in healthcare, and especially with how acutely it is affecting us through this pandemic, these are real issues that affect not only our treatment, but our care, our emotional comfort, our mental health. I consider myself relatively tech savvy. Some people on my team may disagree with me, but I consider myself relatively tech savvy. And I felt a ramping of anxiety as I was about to start a brand new experience. And so what I'm most honored and proud to be able to share with you is this panel of individuals who are experts and experts at humanity. So this will not be all just technical. It will be the pros and the cons. It will be the challenges and the opportunities. Our moderator, our facilitator, who I'll introduce in just one moment, Leticia, I asked her what was most important to her, and she said it is to be real. This is a complex topic. There are opportunities and there are very real challenges and issues we want to be real about, and our panelists all expressed that in our prep call. So I am honored for you to spend this time with us. I will be back at the end to give you a tour of this full conference, the virtual exhibitor booths, and all of the resources that they are loaded with for patients going through COVID. And with that, I see Leticia Ferry smiling. It is my honor to introduce the global lead of Latino achievement for Bristol Myers Squibb, Leticia.
Thank you so much, Dave, and it's a pleasure being here today with you all. And like you were saying, right, Dave, COVID has changed so much all our lives, and none of us had any time to adjust. So suddenly we changed the way we shop, the way we talk to each other. And I just see here on the chat, coming hi from Brazil. So for those from Brazil might be able to place my accent very quickly. So that's where I am from. And just sharing some stories with you, like Dave was saying, now even how we are connecting to our families, right? As simple as that. So now with my family, every week we try all to get together on the Zoom call. And I need to say, sometimes take 20 minutes until everyone is able to click on the link, put the volume up, all the uncles, cousins, right? So, and we have time, right? It's just a family get together. So can just imagine, right, how it would be when you have that time to talk to your doctor and you don't know your camera is not working. So that's why I think it's so important for us today to be real and to talk and to understand all these different perspectives, right? And especially like Dave was saying, we don't know for how long this change will be here. So it's super important, and I'm super excited to have this panel today. Then we can think, learn, and share all the best practice. So with that, so let's get started. And I would like all the panelists to introduce themselves. So can I start with you, Adriana?
Of course. So hello, everyone. My name is Adriana Fernandes. I am a scientist and I'm an advocate. And I am both of those things because I am a patient with multiple autoimmune diseases. So I actually went into science because of that, and actually studied the very diseases that harbor themselves into my body. I have some drugs right now in the clinic that if they get approved, I may actually be able to take them myself. So something very cool that I've been able to do. I now actually lead one of the people business resource groups at Bristol Myers Squibb focused on the next gen voice. So I sit alongside Leticia doing that. And I got into that work because during my patient journey, I saw the realities of the sheer inequities that exist in the medical world. And I know, quite frankly, that I am okay and that I live a pretty normal life because I'm privileged. And I have the opportunity to have a menu and an arsenal of physicians that I see, you know, anywhere from traditional Western medicine to even Eastern medicine to keep myself healthy. So that is how I got into the work that I do now. And I'm just really excited to be here today and be part of this honest dialogue. So thank you.
Thank you so much, Adriana. And I think that's, and as we go through the discussion, that's the important point for us to think, right? All the inequities and the difference on access. So next, Sirisha, can you introduce yourself?
Yes, hi. I guess good morning, good afternoon, good evening, depending on where you are. So grateful to be here and to be a part of this wonderful group. My name is Sirisha Mohan. I'm a clinical assistant professor at the University of Southern California, Keck School of Medicine. I am a family physician by residency and by training. I'm also the lead for our telemedicine program, which started about a year ago. So we were able to stay a couple of steps ahead in this, in the game, so to speak. I'm currently doing a research project on understanding how patients feel about their telemedicine experience. And so we started this project back in October. We've had a wonderful array of different responses, and we're continuing to understand and innovate how to really increase that access to care. So thank you so much, and excited for today's panel.
Thank you so much, Sirisha. Next, can we go to Matt? Matt, can you introduce yourself?
Of course. Thank you, Leticia. My name is Matt Bouchonville, and I'm tuning in from sunny New Mexico. I'm an endocrinologist at the University of New Mexico, which is a hormone specialist. And actually, most of what endocrinologists help out with is diabetes care. So I do a lot of diabetes care. I'm also an associate director of a telehealth program called Project Echo. And I'm so grateful to be a part of this panel. Super excited to see that there are people tuning in from all over the world. So thank you everyone for joining.
That's great. Thank you, Matt. So now can we go to Sandeep?
Thanks, Leticia. Hi, everyone. This is Sandeep. I'm the Chief Medical Officer for a technology-enabled telehealth service called Bluestream Health. We support access to virtual visits from small practices all the way to large enterprise customers. And, you know, my background as a physician, but, you know, doing digital healthcare companies for the last couple of years, it's been interesting to see how the needs of patients are being met now with technology, but also the challenges. So looking forward to discussing that with the panel today. Thank you for allowing me to participate.
That's great. Thank you so much, Sandeep. And I just am seeing here a comment on that people are excited to have an endocrinologist. So I have some news. In fact, you have two. I won't be sharing my perspective, but I am an endocrinologist as well. And Matt and I, we were talking about that. So that's great. Okay, so to our last panelist, Maura, can you please introduce yourself?
Yeah, hi everyone. My name is Maura Al-Ashkar. I am here in Seattle. I'm faculty at the University of Washington, family physician by training, and stage 4 lung cancer patient. My work had been on the experiences of people living with advanced cancers, specifically lung cancer, also doing research work around COVID and how it's impacting different communities, particularly marginalized communities. as part of the accommodations that I received as a physician who is patient as well, I moved to doing telemedicine only. I've been doing that for the past few months. Lots of learning for me and for the community, and it's been, I think it's an exciting time, especially now as the conversation moves towards where the focus is on social injustices and how we can come to remedy some of that. And the health system is definitely at the center of those injustices. So I think telemedicine comes also to be part of that. I'm excited to be part of this panel so I can shed some light on those aspects. So thank you for having me.
You're welcome. Thank you so much. And I think you bring a very unique perspective, Morhaf. So we are really happy to have you here because you can share that perspectives from both sides, right? So thank you so much. So I hope you all can see such an exciting panel that we have today. I will start with some questions, but please, I can see the chat is already very active. So send us our questions because your perspective is super important, right? We needed to understand which are the issues, what are the questions that you might have. So please keep sending the questions. We will try to answer them as much as possible to incorporate them, okay? So let's start. And I think in the intros, right, we were talking a lot how much this has changed the care experience, the relationship. Sirisha even said about all the emotional effects and what she has been doing research. So I really would like to all of you to talk about like how has been your experience as patients, as providers, and as well, I know some of you as we were talking about the caregivers, right? Some of you, how you have been able to incorporate and to bring your caregivers. So what has changed? How that has been? Can I start with Adriana?
Sure, Leticia. So thank you for the question. I think so as a patient, one thing that I have noticed in the time of COVID is my anxiety level has increased dramatically because obviously I am terrified of getting this thing on top of handling my other diagnosis. So having the opportunity to connect with my physicians in a safe way from my home is obviously great. However, there have been some challenges and some things that do concern me. And I'll just share a few of those. So, you know, sometimes when I go to see a physician, they're able to see things that I can't see. So I have some signals that my body presents that can let others know or let myself know that I'm about to get sick. So I have alopecia areata. I actually wear some really cool clip-in bangs to hide some of my spots, but some of those spots may present in the back of my head, right? So I won't necessarily see those, but if I'm going in to see a physician, they can quickly see those and know that something may be coming down the road. Similarly, I might have a skin presentation or something like that I just can't quite get folks to see through the computer. So I do have some trepidation about those things being missed. And then quickly, something else I might just add is that I'm really lacking the patient camaraderie that I get from the waiting room. There are things that, you know, physicians might not think are a really big deal, but they are important to me. You know, like my hair loss or fertility issues or things like that I deal with, that when I'm in a waiting room, I might be able to connect with another patient on those things. And, you know, emotional well-being is huge. It's paramount. It's connected to everything. You know, mind-body connection is real. So to be able to have those conversations in the waiting room is something that I really miss. And perhaps is something that I've gotten a little glimpse might be in conversations with telemedicine experts to have those, you know, virtual waiting rooms so that patients might be able to have those experiences. But that's just some of my feedback as a patient.
That's great. Thank you so much, Adriana. Sirisha, do you want to follow with your perspective?
Yeah, sure. So, Adriana, that's exactly right. You know, when we've surveyed about 300 to 400 patients of our patients that are both new and established patients in family medicine, both from all payers. And that's exactly, if there's a shortcoming of telemedicine, it's the fact that patients miss the exam, the physical touch. You know, while we find that patients feel that telemedicine is extremely convenient and it's great, but they miss the exam portion. And it's true because so much of the time when I'm interacting with a patient, it's their body language. You're right. I can see their overall demeanor, and so much of it is that kind of visualization that is lost with telemedicine, unfortunately. But telemedicine has been great for being able to check in with those patients that have been told to not go to their doctor. At Keck Medicine, we did an outreach program for all of our patients over the age of 50. And we are contacting them individually to make sure that they are okay. We figure out what matters to them. We figure out if they have their medications, and the other important things that's going on. So it's been a balance, so to speak. But at the end of the day, electronically, we are able to at least get some access to each other. And so for that, I'm grateful.
No, thank you so much, Sirisha and Adriana, for your perspectives. And I just want to say, Adriana, thank you so much for your openness and to sharing all that. And I think it's really important for us, right, to make it real, like we were saying in the beginning, and really to share all those experiences. So thank you so much. Matt, do you want to talk about it? Because I think it's very important what you have been doing through your program to enable other physicians. So do you want to share a little bit your perspective?
Sure. Thank you, Leticia. Yeah, so I've long been involved in the telehealth arena with Project Echo, but in terms of utilizing telemedicine for my own patient encounters, it's very new to me, and it's been a steep learning curve. It's been very positive overall, and my patients are appreciating it, but I think it's a steep learning curve for not only patients, but also providers. As Dave alluded to, some centers have gone from like almost no telemedicine visits to now over 80% of their visits are telemedicine. So all of us are learning and jumping on board. I think COVID-19 was a kick in the pants to get us all to go towards telemedicine, whether we were ready or not. And so what I've been involved with up until now with telemedicine has been a telehealth program, Project Echo, which uses video conferencing technology just like this. It's actually the Zoom platform. But instead of connecting a provider with a patient, it is a program that connects specialists with healthcare workers simultaneously, like a whole network of mostly primary care clinicians. And you can think of it as an educational platform. So kind of guided practice, so dissemination of best practices, which can be in the form of a didactic or a presentation, but also a lot of hand-holding and guided practice around also implementing those best practices. And so if you can imagine these virtual sessions or virtual clinics, that's really what Project Echo is. And if you think about a wheel with a hub in the center and spokes, there might be a team of specialists at the hub. And then at the spokes, you have a whole network of primary care clinicians. And we can all see each other kind of like the Brady Bunch or Hollywood Squares. And clinicians will present their patients over the network in a de-identified fashion. So no HIPAA violations, no PHI. And over time, these clinicians develop the skills and the expertise and confidence to be able to deliver higher complexity care to their patients. So the patients are really the end beneficiary in this model. And so they're actually able to receive higher level care and not have to be referred to see a specialist. They can get care in the communities where they live. And so it's a little bit different from conventional telemedicine, where a clinician is connecting with a patient, but very, very complementary to that model. So primary care clinicians are connecting with their patients and through telemedicine. And then these primary care clinicians can also participate in these echo sessions that are kind of building up the primary care clinicians, so they're not having to refer their patients out as much. And so how is this tied in with telemedicine for us specifically? Again, getting back to all of us trying to adopt best practices and how do we use telemedicine, Echo has been really helpful for me to understand how to use telemedicine, and for primary care clinicians and other specialists around the world. We've recruited experts in the field of telemedicine to kind of help disseminate best practices and get the word out very quickly.
Thank you. And that's an important perspective, right? That sometimes we end up forgetting. This is new for everyone, right? So you had this program, but like now, like all of us very quickly, we have to adjust for the many physicians. Like, and and after I would like to hear later your perspective as well, Matt, because I know you have been treating across many regions, right? So it's interesting. Probably some areas are ahead of others. So that's really good. Thank you. But I would like to hear a little bit about Sandeep, because Sandeep can share with us, right, being really about the telemedicine. So Sandeep, do you like to bring some insights in here?
Yeah, no, thank you. It's and as Sirisha said and Matt said, you know, the big learning curve that kind of everyone was talking about, it's not affects just the patient side, because you know there's different needs on the patients, but also on the practice side as well, where doctors and nurses and your care team are trying to be there, but it's you know, the same kind of challenges that patients are kind of feeling in terms of anxiety and being able to have their needs met. It's also challenging similarly on the provider side. So an example of that is, you know, we're all used to working in a collaborative fashion, both with our patients and our own care team members, right? So when Sirisha is seeing a patient, she's working with her nurse practitioners, her PAs, and her MAs. Same with Matt. Delivery. There's unique challenges on both the patient and the provider side. So on the provider side, it's how do we bring that collaborative care model into a virtual environment where it's not as easy to just take someone down the hall to another person's office or bring someone into the exam room like you do today. So those are some of the things that we found were, you know, people got really excited and started implementing these tools, and then they start realizing the limitations, both on the doctor side and on the patient side. So that the anxiety and the personal connection that patients have with their providers, down to the exam. On the provider side, it's really that ability to collaborate, right? So those are some of the technical challenges that we were finding. Fortunately, we were able to model to solve some of those. But so things around care coordination, how do we make sure the right entities participate in these video calls, right? So one of the things that's challenging is in a physical office, you can bring in a language interpreter or a family member to join you. When you do virtual calls like this, because of some of the regulatory restrictions and the privacy restrictions, to be able to do that seamlessly is also happens to be another barrier. So you have to think about how you address those when you're putting in these telemedicine platforms and services, so that, you know, it's not just about making a video connection, it's how do you then take care of that concentric circles of care that go around that doctor-patient relationship. So, and we can talk in more detail, but those are some of the things that we're seeing that we're helping solve for.
No, that's really important. Thank you so much. So, and really, as we go along on the discussion, I really want to talk more about that care navigation and how has been for the patient perspective as well. So, Moura, do you want to share your perspective? And you have a very unique experience, right? You can say how has been for you, being on the patient side and on the provider side.
Yeah, and also on the research side with examining people's perspectives as they lived with cancer. Actually, some of the pet peeves that my community, the cancer community, have expressed a long time ago is the rigidity in the system, where they would be faced with a statement like, no, you have to come here in person, you know, for something that they feel they really did not need to come in person. Like, you know, to know that your CT scan is normal, you really don't need to go there in person. To have a conversation with a nurse to coordinate, you really don't need to go there in person. So now with the health system pushed or forced to do telemedicine, I think that responded to a need that had been presented or asked for by the patient. From the provider's perspectives, again, for people like me who at some point of time wanted to participate, wanted to be there to help with course, there is the duty to care with COVID, but I could not be on the front line because of my health condition. So the space that telemedicine had provided for me to work from behind, to lighten the load on my colleagues, and still contribute care and participate within my own role and purpose was particularly meaningful. I think there are multiple questions that continue to be challenging for us. There is first the task that we're trying to achieve using the telemedicine. So, for example, the primary thing that providers do is to diagnose and to treat problems. So we need to continue to have those conversations to make sure that actually telemedicine is doing that to the best of our capacity. I know there had been a conversation about physical exam and not doing physical exam, and this had been even before COVID. So some of my colleagues and I sometimes joke about it. You really need to listen to somebody's heart when you're doing that wellness visit as a primary care provider, and quite often you really don't, because if the person is doing fine, not complaining about their heart or stomach, you don't need to be poking around for that. Yet many people would say, well, that personal touch is something that the patient wants. It's more than for the doctor or for the diagnosis. So the conversation is going to diverge into two separate areas. Are we medically doing the thing right in the sense of diagnosing and managing the problem to the best way possible? Question number one. Question number two, are we addressing the patient's need in terms of emotions and relationships? And those can be answered, those need to be answered separately, and the conversation for each one of those would be pushed forward as we continue to learn about telemedicine and learn by doing it.
Thank you so much, Murhaf. That's really important, and I really like what you're saying, right? That like now with telemedicine, and this might be one of the good learnings for us for the future, right? Sometimes the telemedicine is bringing us some benefits, right, and make it easier in some of us. So thank you so much. That I really appreciate. So now I would like to move it to a different topic. And I saw here as well some questions are coming. It's really about the disparities, right? And even there is a recent publication that came out on the circulation paper that's really showing that the more vulnerable patients, especially different socioeconomic, patients with disability, older patients, and also when you are talking like now in a globalization, right? Patients that don't speak the local language, right? Here in US would be that don't have English as the first language, have increased barriers to access. And so really I want to talk about and to hear from you. So patients who have all those challenges and don't have access to Wi-Fi, don't have a computer at home, or who doesn't have a phone with camera, right? Don't have a smartphone. So I would like to hear your perspectives, how this has been, how you have been addressing that. So maybe Sirisha, do you want to go first and to share your perspective on that, or what you have been seeing and some learnings for us?
Yeah, sure. So thank you so much, Leticia, for the question. I work and live in the Los Angeles area, very, vibrant urban setting, very diverse. And I don't think it's safe to say, and I think it might be even an understatement, that some of the systemic marginalization of our cities, our people, our communities have existed for years, and really this pandemic is just uncovering all of those issues. And I always, policy is never easy to change, right, until there is a pandemic. And so really, we know that there's poor access to healthcare for so many communities, right? Lack of access to testing that we are continually trying to fix. And so, to communities specifically that is difficult in terms of telemedicine, right? There's the larger, deeper issues that Morhaf was mentioning at the beginning when he was doing his introduction, that are existent. But for telemedicine, we are still trying to figure out what to do for our patients that don't feel comfortable with telemedicine, maybe don't have access to the internet, right? Because the internet is not something that is considered an essential utility. It is not considered as, you know, guaranteed as maybe running water is. And so we have these situations where there's lack of access to internet, and then there's comfortability, and then there's people that maybe don't speak English, and what Sandeep was saying about how do we pull in, you know, language lines, and how do we set something up, and it's really just a total reversal, you know, of turning the entire industry upside down and really evaluating. I almost, you know, when Obamacare was passed, you know, we had this, you know, giant funneling of all these patients trying to filter in through the call center and get access to their doctor. And we've pretty much flipped it. We are now, you know, trying to slowly call all of our patients and trying to get them in to see us. And so it's been a very interesting and difficult, you know, way to kind of, you know, get our patients in, make sure that they're doing okay. So there's been multiple challenges, and things keep changing and will continue to change. But I think it's opportunities like this where we can interact and have a discussion and have a dialogue and figure out what's working and what's not working. And we can only do that if we are together.
Absolutely. Thank you, Sirisha. And that's why I can't reinforce enough how important it is for us to have this discussion today, right? And start to capture and share what is working and what is not working. Matt, do you want to share like what the project ECHO has been doing, and how do you think we should be looking on the lookout on these disparities? I know this is an important topic for you as well.
Yeah, thank you, Leticia. That's a great question. I think Sirisha hit the nail on the head, but I mean, there's no doubt that telemedicine reduces a lot of important disparities in terms of geographic barriers, but it does introduce some new barriers around access to digital technology and so forth. And I think that's most prevalent in rural regions. New Mexico is a very rural state. You know, Project ECHO started in New Mexico, but it's now all over the globe. And so that's a challenge that we work with because it does require access to Zoom technology. Many people can tune into Zoom sessions for these virtual clinics using their smartphones and so forth. And it's not a very broadband heavy program, but many patients don't have smartphones. Now, again, the ECHO model is a little different than conventional telemedicine because there's typically not patients on the network. We're working more with the primary care clinician, who then will see the patient in person, so that as long as there's broadband at the health center, which is usually the case, then maybe not as much in certain parts of Africa, for instance, then we can overcome that barrier. But I think now with more patient interactions kind of transitioning to telemedicine, it's a real problem, and I don't think there's a great answer to that right now. I think there's a lot of interest in changes to the health system to implement maybe more robust troubleshooting for patients. I know our nurses here in the clinic, at the diabetes clinic at UNM, instead of triaging patients, now they're spending that time connecting with the patient, walking them through the process of signing on to Zoom. And if it doesn't work out, we'll kind of transition last minute to a phone visit. I think there's a lot of interest in initiatives to increase broadband access in rural communities, increase access to computers, maybe using community centers. But there again, that's very difficult during the COVID crisis because it might not be safe for patients to be at those community centers. So this is an important question, and I think one that's very high priority right now. There's a lot of interest in overcoming this kind of relatively new disparity.
No, thank you, Matt. Yeah, that's a very good thoughts, and yeah, and maybe this community access, right, might be an option when the pandemic goes away, right? But meanwhile, we need to start to think how we might do this, right, on this situation, and who knows, right, how long this will last. But I would like to bring to this, Sandeep, because you are on the technology side, right? So what do you think, or what are you seeing and what you have been doing on telemedicine to make sure it has access and that really the inclusion, right? Patients with disabilities, even yesterday we were talking about hearing impairment. So what you have been seeing and what you have been doing and what else should we be doing to include those patients?
Yeah, that's a great question. So that's, earlier on I said the ability for working with care providers, right? So for example, my father-in-law has early dementia. So we work with a home health company to facilitate care for him. So at times when right now with COVID, so those sort of service providers could be amplifying access to these care modalities, right? So they could be the ones that have the devices that facilitate that interaction on behalf of the patient. So similarly, PACE programs have devices that are given to home health nurses who go out and actually share a device with seniors that can't leave their house. So there's ways to solve these problems, and it's just a matter of making it accessible and scaling it. So that's where we are seeing a lot of different use cases and applications that are built on our platform to service those. So first is family members, right? So if you have a son, a daughter, or a care provider that can be there to facilitate that interaction, that's one way to overcome these challenges. Just a personal story, when my brother-in-law was diagnosed with cancer years ago, it's just a simple thing as when he'd get sores in his mouth, right, from his chemo, and he couldn't eat. It was really challenging for us just to get someone to understand, hey, use this salt solution or something like that. I forgot what that was, but it was just lacking that access. There are services that are providing care where the patients are, but are not being leveraged with the right tools to connect that or facilitate that connection with the care provider. So I think that's a great way that we can help address some of those care gaps. And second is overcoming that language barrier. So our platform allows for the seamless integration. So when you're in a call like this, you simply click a button and you have access to 200 languages that you can bring on with audio or video. The other thing is empowering. So there's another partner that uses home health nurses. So they're actually parking in the driveway of the patient, talking to them on the phone first or by a video call to help figure out if they actually need to enter the home. So now they have to put on PPE, and if they can avoid that, they're conserving that equipment, still connecting with the patients, literally parking outside their house, checking in with them, and doing that virtual check-in. And if the mom or dad wants to have their son or daughter involved, that's the other aspect of this, right? How do you involve the care team into those discussions? And so, again, it comes back to us, what we've learned. The biggest takeaway that we've learned from what COVID presented is the more you can empower and map to the workflows that doctors and patients already used to, and not have to have them retrain themselves to new ways of using this technology, that's when you get the biggest impact. So not having to change what you're doing and allowing everybody to work at the top of their training level, right? So Matt's trained in endocrinology. I may be having a nurse or team member that can do the triage, but allowing everyone to facilitate those interactions at the top of what they can do and streamline that process. So MedStar example, so if you've seen it in the press, MedStar Health went from about 2 to 3 video visits a day to over 4,700 a day. And that took a lot of scaling, right? So, and people talked about this already, it's how you make the high throughput triage possible. So as a technology company, it's great that we were able to help facilitate this, but it came down to breaking down, how care is delivered today and allowing everyone to understand you don't have to change what you do, but you have to fit the technology so that it allows people to continue to do as much as they do today without having to retrain everyone. So those are the big learnings that we took away.
Oh, that's very insightful. Thank you so much, Sandeep. So I would like maybe to go back. We were talking a lot about all the technology, but go back to patient care, and even Adriana was saying in the beginning how is important the relationship, the emotional, right? And even us as healthcare providers, as physicians, right? All our training is a lot of based on the relationship. We need to do the physical examination. We like to see the patients and to talk. And so we got here a question. So I would like to hear first from Maura, so how are we doing the physical examination? Is that important? Is not? So where are we on that? And how are you doing that now?
That is a very good question. The physical exam has multiple components. Many of it can be done with the person in front of you demonstrating or exhibiting particular features or behaviors or symptoms that the person can see. A lot of stuff we cannot do, obviously. We cannot yet, hopefully with Sandeep's work, we can start developing technology that allows us even to listen to someone's heart when they are at home and we are in our own offices. I think there are some of those movable devices. But at this time, a person, for example, a mental status exam, a lot of it is the feature in the face, a lot of it is the mobility or the movements that person exhibits in front of you in the camera. So all of that can be given. Even with COVID, actually, we had the template that you check in a few of the symptoms, the absence or presence thereof. For example, if somebody is fatigued, if somebody is lethargic, you can see it from their facial expression, you can see it from their droopy eyes, you can see it from how they're looking, how their posture is. So there are a lot of those signs that you can actually get without touching the person. Same thing with breathing. You can tell from conversation, for example, I just said a full sentence without having to stop. Now I stopped. If I'm not finishing a sentence, for example, you can tell that I am short, breathless. So there are some of those that can be found just in a conversation with somebody. Yes, there is a loss of that physical touch which convey a relationship, but there are a lot of information that can be actually gleaned without having to put the hand on the person. I think relationship, it's often debatable actually whether yes, let's think of it as tools or techniques that we use to convey connection or care. When I reach out to a person by phone or by telemedicine to say, hey, I'm calling you because I care, because I want to see how you're doing, and when my staff is reaching out multiple times to make sure during COVID that the person is not alone, the person is receiving that connection. That person is often, I've heard lots of gratitude actually during the COVID pandemic that I have not heard before while I am sitting at home. People have expressed appreciation for healthcare providers who are first on the front line, but even the ones who are sitting behind and they're still continuing to care for others. So the person is appreciating that kind of care, and that is lending to development of that genuine connection or that relationship and trust. So I would call to expand again our list of things that we do to communicate that we care and that we actually genuinely want to service. And I would finish with this actually, and some of the things that have helped in my experience is an attitude that this is a service provided for the person, and this is essential in our calling for duty as healthcare providers. What we're doing is service for people, for the community. So often when technology becomes hard, you switch it to a phone call and you get the person's need met, and we're doing what we can to help for whatever that person needs. And then if that phone call did not work, then by email. So it's more of how can we most flexible and adaptable to meet the person's need where they are, and again reminding ourselves that we're responding to what that person wants. Our focus is that person's need. That technology or the specific sets of action that need to be performed in every specific visit may or may not be necessary to achieve that end.
Yeah, Matt, do you want to add some thoughts here?
Yes, thank you, Leticia. I agree with Moura. And also I wanted to say that a patient that I saw virtually this morning was fortunate enough to have a home blood pressure cuff. And so some people are able to check their vital signs at home, but there again, access is a problem. And I would say the majority of my patients don't have the ability to check a home blood pressure. There was a question earlier in the chat from Donna, I believe, about diabetes care, and being a diabetes specialist, I do want to speak to that I think diabetes in particular has over the last 10 years or so really transitioned to more, as you know, Leticia, as an endocrinologist, has transitioned to more technology use. So insulin pump therapy, continuous glucose monitoring, even hybrid like artificial pancreas technology. And that actually lends itself really well to telemedicine, in that we can actually download these things. The patients can upload all of this really rich data, checking their sugars every 5 minutes, these devices. And we can really get a great, pretty comprehensive picture remotely via telemedicine. But that takes some expertise as well, like learning how to use the software for patients to upload their data for us to review with them. So a nice thing with using video conferencing technology is sometimes we can actually just have them like kind of point their insulin pump at the camera, or their CGM at the camera, and we can kind of walk them through. But I think adoption of technology in the setting of diabetes care has made it easier to conduct diabetes care visits via telemedicine. But another problem I didn't bring up right now is that access to those technologies is also a barrier too. So that's an important thing to keep in mind.
Yeah, thank you, Matt. And I think, yeah, exactly like what you were saying and Moura was saying, right? We all need to be flexible, right? And understand where the patients are, right? Your patient, they had the blood pressure cuff, others might not. So and I really like what Moura was saying, can be telemedicine. When you might need to do a phone call. And probably more than ever, right? All of us, we need that human connection, and patients do really need to be connected. I really want to hear from Adriana as a patient, and one of the questions as well came before is all the psychological safety. So Adriana, how do you think for you, how has been your experience in all of these, no physical examination, reaching out? So do you want to share with us how has been your experience?
Yeah, sure, Leticia. So I think Moura said the word trust, which, it's critical. And I think when we talk about health inequities and we're talking about minority patients who haven't historically had the same access to care, it's really, really important to foster that. And I think a watch out is, at least something that I've experienced, is when you're in a physician suite or a practice where they have many different physicians. Sometimes the patients can get shuttled from one doctor to the next. And if patients don't have that trust already embedded with a physician, or even if they do, and they want to keep seeing that physician, I think shuttling them around can be extremely detrimental, especially when we're talking about telemedicine. It takes so much to build a relationship with your physician. And if you feel like you're just getting, pushed from one doc to the next, it's going to be really hard for you to trust them. And I think that also ties into the physical examination. I feel much more comfortable getting in front of a camera. And actually, I've had to shine multiple lights on myself and do all of these crazy things so that my doctor can see what's going on. I feel much more comfortable doing that with someone with whom I already have a rapport and a relationship. So I would just urge everyone to be really mindful of that. And also, there are things that in person, it's just, you get that connection piece, whether it's just, a brush on the shoulder if you're feeling worried about a diagnosis that you've just been given, or that eye contact that I know studies have shown that virtual eye contact is the same as in person, but there's a lot of data that's now saying otherwise. So, being really mindful of finding ways to connect, even if that's just, critically listening to your patient, and the next time that you see them, bringing up something that you said, they said, so that they know that you're listening to them and you're valuing them. So again, I think this is particularly important from a health inequity standpoint, because as I mentioned earlier, there are so many patients that they just don't trust physicians, both from regular care all the way to clinical trials. I know that's a whole separate topic that was touched upon last week, but how can we improve that and improve that in this unique time where we're relying upon technology, which is an additional burden for many patients? So I think, and it sounds like, you are already thinking about that, but I'm hopeful that these conversations will go deeper and become richer to make sure that we're not, increasing that gap for a lot of folks.
Thank you so much, Adriana. And I really appreciate, as I said before, you're being so open and sharing with us your experience. I would like as well, we have been going back to the technology. So, and as we know, many patients, like similar to what Adriana was saying, have multiple disease, right? You might need to go to the endocrinologist, to the rheumatologist, cardiologist. So all this coordination of care. And let's say if you're not in a big university center, each physician might be using a different platform. So my question would be, and I would like on this one, I would like really to hear everyone's thoughts. How has been for you as a provider to navigate that and that integration with EMR and telemedicine? And for the patient perspective, right? So many different ways how you put all those pieces together. So that integration. So maybe let's start with Sandeep, with your perspective, right, from the telemedicine, how you have been seeing, and from your side, have you been able to see that coordination coming? And as well, when we go to the physicians, right, to the HCP providers, also the billing. I know there were some challenges. Were you being reimbursed for a phone call or not? So maybe Sandeep, let's just start with your perspective from the telemedicine platform itself.
Sure. Yeah, and there was a lot there. So, before COVID happened, right, a lot of the barriers to adoption, unfortunately, came down to what was reimbursable and what was not, as well as some of the regulations around licensing and state-to-state care over state licensing, between where the doctor and the patient were. And COVID, kind of made everything disappear. And it's amazing how things work when those barriers are gone. And so beyond the payment issue, like you mentioned, there's similar to what was happening, what we're seeing on the EMR with data blocking issues and interoperability issues. The same challenges exist, right? So if you have a primary care doctor that uses one telehealth platform and you have another doctor that uses another telehealth platform, you're likely to have 4 or 5 different apps on your phone, so you can talk to these care providers. So fortunately, there are ways to work around some of those. But a lot of the times, unfortunately, it comes down to, again, what was available to your doctors and nurses for the way their certain EMR may have implemented a workflow, or for a different practice. That's because there was no kind of standard around how these should work, and it's always going to come down to what's convenient for the patient and the doctor. So what we found successful is just to make it as simple as possible. So eliminate the need for downloading something, right? Don't have someone be prepared. So I went through this myself. So a couple of weeks ago, I started getting phone calls because I had my own primary care doctor said, hey, our visit is going to be through telemedicine. But that required a lot more extra work, which we thought would be a lot easier. But the practice had to have someone set aside, making phone calls out, making sure the patients were ready, making sure the app was downloaded. And then 2 minutes before my session with the doctor started, I literally get a phone call that almost made me miss my video call, which was, we need your credit card for a copay collection. And so these kind of things happen all the time. But when you walk into an office, you can handle that, right? But now it's a whole layer of challenges, and it adds more stress, right? I was stressing out that I was going to miss my 15-minute call. I was going to have to reschedule for sometime in September. But yeah, so those things happen. And so what we're finding to be really simple is there's a lot of tools out there that allow you to generate a link at the time a doctor's ready. So you don't have to download something. You get a text message or an email, you just simply click and you're in the call. All of the security parameters are in place so that there's no requirement for download, install, registration that you typically were seeing beforehand. So that's definitely a plus on the patient side. And then the language as well. So if you're going to text somebody a link, you have to make sure that that text message is in that native language, right? So those are the kind of things that you have to think about. And it changes the entire workflow, right? Just because you click on that link, now you're in a page, it's in English. So these are all small things that people are starting to figure out. But the good thing is that it's accelerated a lot of this need for really understanding this is a whole new way of delivering care, and it has its own set of challenges. So just like you go through training and how you tease out a history and do your physical exam, people are going to get retrained now on how to use these new delivery mechanisms and what are the things that patients can do to prepare and what are the doctor and the nurses are going to do to prepare. But it's keep the simplest thing that you could do to enable these services is what is going to allow it to be successful. And Medicare is actually looking at this right now, really understanding which services are best provided through telemedicine. Like, what is that kind of in that spectrum? What is the decision-making process that lets you know, hey, this is a perfect session that we can do virtually, but you know what, for some of these other things, let's bring you in. But having to figure out that actually is a good thing, right? Now you free up your office time for those patients that really need to be seen face-to-face, and you can shift a lot of the other care that could be done virtually, especially for the convenience and collecting, disparate parties, the family members that are not together. So I think people will get better at this. Right now, everyone's learning together, as Matt said.
Yeah. No, that's good. Thank you. And I can just imagine, right? Like all the stress, like you're saying, right? Everything on the phone, you got a phone call, right? It's like you can't talk to anyone, right? Suddenly everything, and now our lives in our phones. So that's very good. Similar to that, but I would like to hear Sirisha's point, because as well with this COVID, right, this pandemic, some of us might be in our home state, other people might be traveling. So, and I heard, Sirisha, you had some examples about all the challenges that might pose on reimbursements, right? So can you share with us, like on top of all these complexities, right, really the billing, and what if you're out of state or even out of country? Does that add additional challenge for the patients?
Yeah, Leticia, thank you so much for the question. I can't tell you how much I resonate with what Adriana was saying about trust and what Sandeep is saying about collecting the copay. That's exactly what my IRB project, my research project is understanding the patient perception of the copay. And about 30% of my patients feel that it's unreasonable. Because, hey, if your doctor's not giving you a choice to come in, why are you expecting this copayment? So I just resonate with what you both were saying so much, because trust to me as a family doctor, I always tell my residents and my students, it takes 3 years to really establish a proper trust with a patient. And so it's really the fundamental, and Morhaf, you'll those are, continuity is like the foundation of family medicine as well as behavioral health. And so Morhaf and I can probably toot the horn for family medicine all day long, but I won't bore you with that. But you're exactly right. The CARES Act, which was passed on March 6th by Congress, really waived and relaxed many of the previous rules about Medicare. Before, Medicare was just allowing telemedicine services in those rural places that were considered, I'm sure in Matt's area, he could probably speak to this as well. So it relaxed for Medicare, relaxed for Medicaid. I remember I had the most important things that we experience as providers is the experience of our patients. And I remember I had a dialysis patient of mine that rode his bike to come see me every visit. And, he saw my, I have like a telemedicine kind of poster flyer thing in the lobby. And he's like, when can I do that? When can I do telemedicine? I said, sorry, you're on Medicare. I can't offer that to you. And really the CARES Act relaxed much of that. And I think FQHCs specifically, federally qualified health centers, really benefited the most, hopefully, and will continue to benefit. But Leticia, going back to kind of your specific question about borders, I have to go by the state where I'm licensed, and I'm licensed right now in the state of California. And so the California regulations, and these are changing all the time, but by California regulation, I cannot see a patient unless they are physically located in the state so if they're in another state, I can't see them through telemedicine. And obviously Keck being a cancer center, the Norris Cancer Center, we have patients from all over the world across the country. And so it's definitely been a barrier to be able to provide these services. Right now we have a waiver that we have to sign. So if there is an emergent issue, we are able to still provide medical services. And I know that at least the United States, the Federation of State Medical Boards, FSMB, I believe it's the acronym, are trying to come up with a way of doing like a multi-state license, so that way you can be able to see patients across state lines and still be within the regulations. So I think that's all still in development. Of course, we're having to, we're not really getting a chance to learn how to crawl. We're just, going straight for the marathon as we charge forward with all of this. But it's definitely, I just wanted to also just go back to the workflow and really that care team model. We've spent all this time putting structures in place so that everyone on the care team is involved. And, we have family physicians that are FaceTiming their patients. And so the comment about the platform is definitely, it's difficult and it's going to remain a challenge. And I was just wondering if there's anyone on the audience that may be in a different country where obviously we could probably have a whole other panel about how complex the healthcare system is in the United States, right? But what's happening in places that have more universal healthcare systems? Is there one single platform? Is it making their ease of telemedicine? Is it making it easier to do telemedicine? I would love to hear from the audience if they have any experience with their platforms in their countries.
That's great. And in fact, that might be a good segue. And I would like to hear, Matt, your perspective, because I know Project Echo, you have been touching and in contact with many different regions. So while we wait, if we get any insights from the audience, Matt, would you like to share your perspective and what you might have learned on the Project Echo and through the different points that you have been touching?
Yeah, absolutely. Yeah, great question, Leticia. Thank you. With respect to working with I alluded to this hub and spoke kind of shared knowledge network sort of model. And again, this program started in New Mexico, but it's now all over the world. And so you can imagine, and now it started with hepatitis C treatment. Now Echo is being used to treat a variety of conditions: diabetes, cancer, multiple sclerosis, you name it. And so you can imagine these hub and spoke networks are now all over the world. So there is a very robust infrastructure now. So one thing that we have been very excited about in recent weeks, like one bright side, I guess, during this pandemic, is that with that infrastructure, we can very rapidly disseminate best practices that are emerging, like new guidelines in the setting of a health crisis such as the COVID-19 pandemic. So these existing networks now have kind of pivoted and been activated. So all these networks that were being used around the world for cancer treatment and diabetes and so forth are still doing that, but also have expanded and activated towards the COVID-19 response. And so what we've seen is globally, there's just been a very rapid spread of guidelines. And as you know, with COVID-19, the guidelines for screening, for treatment, they're really changing day by day. The science is changing from day to day. And so just one example, if we look at our partners in India alone, just over the course of like 2 months, 2 to 3 months, I mean, when the pandemic started, so in like March, or actually it started before that, but just over the last few months, India has reached over 200,000 frontline workers to respond to COVID. They've reached over 45,000 doctors, and so they've really increased the knowledge in their healthcare workforce around how to deal with the COVID-19 pandemic, how to treat patients for their existing chronic conditions, working around the COVID barriers. So that's what we've seen firsthand.
No, this is great, and really like what I have been, as you were talking, right, and some of the comments, this might be one of the positive sides, right? If we get those learnings and after are able to change and kind of a universal care, right? Hopefully there might be some good things in there. But later as well, and we can talk more, but the question that I'm thinking now, and probably you that are in the university, like, should we relook how we are teaching training, right? Nurse and physicians, right? Maybe like you're saying, because this might be the new normal, how we are going to incorporate that into the training curriculum, right? To make sure everyone is well equipped to do that. Okay, but I want to hear as well, Morhaf. Yes, do you want to jump in here, Morhaf, and really to talk about your perspective on this, and
Yeah, I can
especially.
comment on
Yeah.
the training part. I work with residents as well at the University of Washington, and you are right. This is a new learning, and we're all going to have to do it. There is exciting opportunity with telemedicine for the preceptor to be there in the room without being obtrusive or intrusive or even appearing. You know, you can just log in. You don't have to show your video. You're mute, and you're just being there. And that's probably the least obtrusive way of coming to see how the interaction is happening. And I'm one of the people who value language communication, language-based communication the most. I think we have developed sophistication in saying what we want and what we mean, and there's a lot of work around that. So I do find a lot of opportunity in learning that and some of those skills that then can be even transferred to the in-person communication. I wanted to comment on something Adriana mentioned earlier about trust, and I think this is a really essential thing. And I want to take it also into the dimension of this, bring it back to link it to disparity. So in the United States, there are over 40 people who have no insurance, and additional 35 million who are uninsured or have inadequate insurances. The ones who are insured also worried about copay. So I think there's a problem, there's a flaw in the system. When we're talking about trust or not trusting the system, we can talk about that lack of adequate communication, not having the physical touch, etc. But I don't think that's the heart of the problem. The heart of the problem is that a system that's founded on profit and communities marginalized, underserved, are not having access to it. Healthcare in the U.S. is a privilege to those who have, and it's not available to many of those who do not have. I think rethinking the bigger framework is essential. Telemedicine potentially can provide some of that. If I am sitting at home in my own bedroom wearing nice top down in my pajama pants, I probably should not be paid $100 for a 15-minute visit. I think rethinking the cost, because it's really not going to cost that much. It costs a camera and a computer. So rethinking the cost that people have today, rethinking the copay is something that we need to move forward with. And these are some of the challenges that we need to rethink. And it doesn't have to be a problem. It doesn't have to be at the expense of medical centers too, because I know I come from an institute, and we need to get paid so we can continue to provide serving, especially in primary care, the underserved. But I think when we're rethinking how we're doing healthcare delivery, with part of us staying at home, doing that telemedicine from home, and then opening the space for other providers to occupy that extensive space in the clinic to provide more sophisticated and that services that require people to come in. I think if we thoughtfully re-examine how we deliver the system to leverage again the space and see what can be done from home with low-cost services, I think there can be a radical re-examination of how the system, why the system is costly, and how we can cut some of that, potentially with also engaging nonprofits to deliver some of the care to the communities that are not receiving care now. And that is where trust can be, again, regained with the community at large.
Thank you so much for your perspective. And another thing that is coming that we have been, I think might be a problem, right? We are talking about co-pays and all that. And as soon as you finish the visit, the next step for the patient, usually you might have a prescription, right? So my question and that I really would like to hear from all of you, when you are finishing the appointment, right, with the patient, first, and we know sometimes we explain you are prescribing A, B, and C, how you make sure the patient understood if there is a change, especially if there is a change on the prescription. Because when you hang up, right, then that's it, you are gone. And the patient cannot talk to your receptionist to make sure she got it, where to go. And where I'm going, there is also, there might be the copay for the prescription drug, right? So it's a lot of copays, and and the system is not easy to navigate. So maybe if I can go, just restart with you, Morhaf, like how you have been doing that to make sure the patient understood what you are explaining, you are prescribing, and that they know if there is a high cost medication, might be a copay, and how to navigate that. So any insights in how you think has been working for you and your patients?
I'll be brief since I talked a lot to last. I think this is an extension of things that we have used before. I find with telemedicine that there is a better opportunity. People are hyper alerted to their devices now. People are more in tune to that, that computer kind of communication. So when things are falling into the crack, often I'm receiving a communication from someone, and that's being addressed by phone or by a follow-up telemedicine. I think people are more readily accessing those devices to bridge those communication devices than before. That's generally my judgment, but still I think we can always do better with communication. We can still do better with clarifying things, but the essence of that linguistic dialogue again is the same as in person as it is in the telemedicine, so that shouldn't be changed drastically.
Adriana, do you like to share? I don't know how has been your experience now, and how this has been changed now with on this virtual environment.
Yeah, I mean, I completely agree with Morhoff that, the foundation is where the problem lies for trust, and payment is part of that foundation. Everything does go back to the dollar, right? Unfortunately. But as a patient, I have to say, not only, do I hope that the cost structure changes, but I also hope the transparency around that changes, because it is so confusing to know what I'm being billed for. And I feel like oftentimes, especially if it's a hospitalization or some sort of like outpatient procedure, I will get this number and there's like 3 line items there and nothing makes sense to me. And when I call and try to get more information, no information is given to me. So again, there goes the trust, right? I don't understand where these numbers are coming from. So yes, it can be very frustrating. And, in the time right now of telemedicine, there's an extra layer of confusion, because it seems like most of the places that I see, like the cost structure is not consistent. So I'm not sure what I am paying for. And when I'm going into a visit, sometimes I don't even know what I'm going to walk out with from a bill perspective. So transparency around the cost and the bill is going to be very important.
Thank you, Adriana. So Sirisha, do you like to follow and just to share that perspective from your side, right? For how has been all this payment, how has been the challenge for you that might have been having, and as well I'd like to hear for you senior patients going back to the prescription and closing the visit, right? How you have been doing, and what is kind of best practice that on that you think has been working better?
Yeah, Leticia, thank you so much for the question. It's complicated, right? I want to say that I'm trying to do the right thing and making sure, okay, do you have any more questions, comments, concerns? Is everything clear? Because a lot of what, like my direct counseling with patients, I might skip over something that, right? Like, and Matt, you used the word, what did you use? CMG, or CGM earlier, all the time, providers are using either acronyms or very language that we just think is regular, EKG or, INR. And so we use all these different, acronyms all the time. And it's just in my blind spot, right? It's not that I realize that I'm not communicating effectively, but communication is so important. We've, and I know this is a little bit off topic, but we've tried. So we just have to increase communication as much as possible all the time. And, and so a couple of, I don't want to digress too much. I want to make sure I stay on your question, but, it's very difficult. I get so frustrated sometimes because, I want my patient to be, if they're coming into me in person, I can direct them to my checkout desk and get that follow-up scheduled. I can make sure that they're, getting their blood work or getting their imaging. But, with all of the physical distancing in place, it's like, well, we can't have too many people over here, so we're just going to call them. And then now we're just relying on multiple phone calls. And it's just getting more complex. And I think, Sandeep, that's kind of what you were kind of saying earlier. So it's, that's definitely something that is difficult for providers and physicians, both prior to and during this pandemic, is how to communicate with each other. And I definitely love the suggestion of just texting. It's easier. It's, maybe more direct. So I hope we continue to innovate in that area. And in terms of, Adriana and Maura, thank you so much for just, highlighting the issues with trust in our medical system. I don't think I need to explain to anybody on this panel or attending that there has been so many atrocities against, our Black and Brown communities that have contributed to the issues with trust in our medical system. And Adriana, I loved that concept of just, if you feel better, if you feel like you can trust a provider that looks like you, state regulations should not prohibit you from being able to connect with somebody that you trust. And so I love that innovation. But, and Morhaf and the other providers can tell you, medical training does not include how patients are billed. And so, sometimes the analogy that I try to use is like, you go to a restaurant and you take out the menu may be up there, that you're buying that sandwich and that bag of chips and that drink for such and such cost. When you walk into your doctor's office, there's no cost. There's no, okay, this is how much, you have to pay for this and this. And so there is so much, there's a lack of transparency about things. And even the providers, well, do I know that you're going to get charged this fee if I label it this way, or maybe associate it with this diagnosis code versus this diagnosis code? It doesn't get taught. It's only the school of hard knocks, which makes it so difficult. And that definitely needs to be addressed. So yeah, so many important concepts and things to discuss.
Thank you so much, Sirisha. And I think that's so important, right? To see how many gaps, right, we have from both sides, lack of transparency. So the system is really hard from both sides to navigate. And that's where the trust come at the front center. Matt, would you like to add some thoughts in here?
Yes, just briefly, thank you. So I don't know that this is a best practice, but I tend to share my email address with patients in case they do have questions, because often if they try to call the clinic afterward, I might not get the message. They can be on hold for an hour. But also part of our discharge process after a Zoom visit or a phone visit is to have the nurse or the MA call the patient afterwards with their next appointment and see what questions they may have. But Adriana brings up an important point about trust of the healthcare system. And so a lot of the clinics that we're reaching out to through the ECHO program are utilizing community health workers that kind of act, they're really peers within the community. And the community health workers act as a liaison between the provider and the patient. And so they will often, before COVID, they would do a warm handoff. And so the provider would discuss the plan with the community health worker, and then the community health worker would meet with the patient. Now that's happening via telemedicine. But I think that's one way to help bridge that gap in terms of trust of the healthcare system.
No, that's great. Thank you so much, Matt. And I would like to take the discussion next, Matt, in a comment that you were making about all the guidelines and how quickly things are changing now, right? And like all these publications, and then on top of everything, we have COVID, we have all the media on top of all, sometimes trusting healthcare, sometimes not trusting healthcare. So I think more than ever, there is a high pressure in all of us, right, to be on top of what is coming, to adjust to the telemedicine. So I would like maybe to start with you, Matt, since you brought this and you are dealing with many different regions. How are we doing, right, to keep up with this fast-pacing environment, all this new evidence coming up quickly in different directions? So any thoughts or insights here to share with everyone?
Thank you, Leticia. Very important question. And I think the short answer is it's impossible to keep up. Once we get our training in medical school or nursing school or whatever kind of training we receive, you kind of come out with thinking you're on top of all the literature, but it changes on the first day of work. And so, again, coming from an echo perspective, we use this model as a means of what we call democratizing specialty knowledge, democratizing medical knowledge. But it's important to keep in mind that it's a multi-directional flow of knowledge. So best practices are being disseminated from hub to spokes. But if we only operate within our specialist silos, we aren't as effective, and we're not really delivering as high complexity care. We might be aware of our guidelines, but think about a patient with a complex condition like diabetes. I'm not on top of all the nephrology guidelines or behavioral health guidelines, all of these other specialties that are so important in the care of a patient with diabetes. And you could say the same for anything, cancer care. So working in a collaborative kind of space where we're learning from each other and also from the spokes, from the frontline healthcare workers that are kind of teaching us how to implement these best practices within the confines of available community resources becomes really important.
Yeah, so Sirisha, any thoughts here that you'd like to share, how you and your organization are keeping up with on this fast-paced environment that we are now more than ever?
Yeah, sure. Yeah. So I'm fortunate enough to be a part of an academic medical center, and so I actually was just having this conversation yesterday with a colleague of mine. We have a because I was like, there's so many things. There's remdesivir, now there's dexamethasone. Where do I go? How do I practice evidence-based medicine in this pandemic? And so, very important question, and I appreciate it. But we have I'm lucky to be a part of KEC that has a separate group that is continuing to evaluate and putting together best practices, and that's updated pretty frequently. I think the latest one was put out on the 12th, and so it's available to all providers in a very central location. And so I do my best to pay attention to that, but it's information overload, right? And I think that going back to the kind of psychological impact of all of this is it's just, not only do we have all of the daily emotions and thoughts that go through our own brains, and then those of the ones we love, and then you have our maybe our neighbors, and then you have our communities, and now we're as a state, and then as a nation, and then as a world. And so the amount of information that is constantly being thrown at us, it's leading to this chronic stress and leading to so much of not only substance, maybe increase in substance use, and then mental health issues. So integrating that into the multiple complexities of everything that's going on, it's difficult to navigate. And I hope we continue to figure out what best practices are. And, going back to kind of my trust with patients in telemedicine is, one thing that I've started to do is to say, are you in a safe place to talk to me right now? So that way they do feel safe to be able to talk with their provider, because I can't see what's happening outside of the screen. So I've definitely tried to incorporate that as a best practice. But maybe I've also been starting to ask about how are you doing financially? Do you have enough food to eat? So outside of the kind of direct COVID treatment guidelines, those are kind of other things that I'm trying to do, at least as a provider, to make sure that I'm kind of bridging those gaps. And I'm sure other providers have similar stories and recommendations.
No, that's so powerful, and that's absolutely right, right? Because the COVID is having a huge economic impact, and goes back to our initial discussion on all disparities, right? So more than ever, it's important that we understand where the person is coming. Do they still have their job? How are the kids doing? And we know as well, many of them might have someone who they might have lost a loved one, right? So it's super, it's yeah. So I really like your best practice. So maybe, and I know we are getting close to an end. Oh my goodness, we could stay here for such a long time. So before we close, maybe I just would like for you to think about it, like knowing that this might be, like you're saying before, telemedicine might be here to stay. Some advice, best practice, and what do you think it's working, and some things that you should watch out, right? And we should probably stay away. So just some final thoughts. So Sandeep, can we start with you?
Sure. Yeah. No. Thank you again. Like I said, everyone's touched on this before. It's really comes down to workflows. Like, what are the workflows that the patients have to do, and what are the workflows the providers have to do? As long as you're mapping whatever you're implementing against those workflows, you're likely to be more successful than less successful. And the handoff issue is one of those examples, right? So our platform actually helps facilitate that. So when Sirisha is done, she could bring the nurse into the call. She could leave to go to the next call. So you have to be able to mirror those real world workflows in this virtual environment. So that's my one piece of advice.
That's excellent. Thank you so much. Maura, do you want to go next?
Yeah, this is really exciting time to have those conversations about how we can leverage this relatively cheap tool to provide care that is needed to a larger population in a way that is convenient to them, and also develop our competency to convey relationship and trust and support to a person wherever they are. I would also encourage us to advance those conversations so we can reach beyond, especially to communities and individuals that have not benefited from the privilege of having healthcare. I think there is a lot of work that can be done for nonprofit in this area, potentially bringing people who want to work to contribute. Imagine a system that can be done for pro bono work across the state, where every provider would contribute 1 hour of work. If you have 1,000 family doctors giving 1 hour each pro bono, that's like tons of patients that are not being seen now getting seen for free. That would be really good, and I think I would challenge us to think about that. I'm hoping to continue that conversation with some of the panelists and in my community here in the state of Washington about how that can actually become actual.
I love that, right? Let's really challenge ourselves, call to action, and like Matt was saying, right? That's really good. Excellent, thank you. Matt, do you want to go next?
Sure, thank you. Just from the echo voice perspective here, and keeping it more patient-centered, I would encourage patients to visit the Project Echo website, and there are interactive maps, because there are echo sites now all over the world. And as I chatted to someone in the chat, there's been just increasing interest in adoption of actually having patients on these echo hubs and providing that important, vital, missing piece, the patient perspective. So expert patient advocates, expert patient representatives. So I would encourage you to explore opportunities for serving as a patient advocate on one of these echo teams, for a diabetes team, a cancer team, an autism team, what have you. Thank you.
Yeah, that's great. And more important than ever, right? Like here talking about patient centricity, we really need to get the patients engaged and get their voice. So Sirisha, do you want to share your final thoughts?
Yeah, I mean, I think when we started telemedicine at USC, it was really to increase access to care. And what does that look like? And what is that going to continue to look like? And I just really appreciate all these conversations, because it's going to take us to work together to figure out how to innovate and stay in communication and stay connected as we work through all of this. So I just appreciate being part of the conversation.
That's great. Thank you so much. And Adriana?
I feel like, a lot of folks have already touched on it, but we're in a time of change right now, and it's a lot of change. Telemedicine's part of that change, and sometimes when you're moving through change, it can happen really, really fast, which can be good, but it can also be very detrimental. So I would just urge us to be cautious and put really careful pauses in what we're doing to make sure that while we're going through this time of change and this time of really fast change, that we're not doing things that are going to just increase the gaps that are inherent to our system. So I think it's really important for all of us, you know, for me too as a patient, to take those pauses. And when we take those pauses, make sure that we're being as honest as possible, and keeping an open mind to have conversations that make sure that that change is doing the right thing.
Thank you so much, Adriana. And I think that's why this forum today, right, more important than ever. We should not stop this conversation here. We need to stay engaged, keep watching out, and keep looking, right? Because this might benefit a lot of patients, while others, those disparities, those gaps might increase. So more than ever, we need to be very engaged and be part of these conversations. So I couldn't be more. It was such a great 1 hour and a half. I can't believe we are coming to a close. So thank you all so much. Thank you all for the participants, for being such engaged in the chat. So it has been a pleasure being here. So thank you so much. And I think now I will hand over to Dave. Dave, are you back?
I am here. Thank you so much, Leticia. Oh my goodness, I have so many post-it notes in front of me from notes I was writing feverishly while everyone was talking. And what really strikes me about this panel, not only all the smiling faces I see on camera right now, but all the different perspectives we heard from physician and scientist and researcher and patient. And it really strikes me how much humanity was the core of what we talked about today. And I was just so really grateful that one of the comments that stuck out to me was how long it takes to build relationships and how much trust is really at the center of all this. And I thought you hit on such important topics that as a patient and a professional, to me, are things that have to coexist. Trying to make sense of everything we talked about. Adriana, I hope it's okay if I go back to something that you started the conversation with. And I'll probably get emotional talking about it, so I'll warn you in advance. I hope everybody appreciates the courage it took to admit the bangs and the things that we do as patients to feel normal. And, you know, patients are equal partners in all of this. And what grit is all about is finding our voice and using our voice. And Adriana, I can't think of a stronger example of having the courage to share the things so that we can have open conversations. And I thought everybody, you know, was in that same place on this conversation, talking about how it affects the provider and the patient and the researcher. And it was so genuine and so remarkable. So to Leticia and all of our panelists, I can't thank you enough. And we will be back next Thursday. And actually, what we talked about today was really the visible and invisible parts of telemedicine. How do we understand the things inside of us as patients and caregivers? Next Thursday's session is mental health, and it's well-being for patients through cancer. And that's, you know, another step in the direction of how we find courage to talk about things that are really challenging and lean into those tough conversations. And so we welcome everyone to join us again the 25th, next Thursday at noon, for this next panel. I will spend more time next week walking through walking through all the resources and sections in this virtual conference next week. But I would like to make an invitation and part the conversation that way. We are moving into sharing resources and elevating the work that everybody's doing. So if you are an advocate or somebody that is developing resources, researchers, professionals, the grit contact email is contact@grithealth.com. And if I can ask somebody on our team, maybe Lauren, who runs our programs, just to add the contact@grithealth.com in the chat bar, reach out to us. Please let us know what resources you're working on or the resources that you want to see. And as we continue building this relationship, this advocacy exchange relationship, we want to make sure we're including all of those in it. So would like to close by thanking Bristol Myers Squibb for supporting this and making it all possible, the Evoke Kind team for being humans that care about moving humanity forward, and our Grit Health team who really cares about helping people find our voice and use our voice for ourselves and for others. Really grateful to spend the time together. We hope to see you at the COVIDadvocacyexchange.com anytime, and again next Thursday for the mental health panel. Thank you, everyone.